to have the first of stage 1. Anybody know? Isn't it 140 as a diastolic?
Yeah, so, oh yeah, the systolic is 140 to 159.
I mean, yeah, it's systolic. And so in order for it to go to a 2, it would need to be 160. So I have that 152 over 85 would still be a stage 1. Now, they do have, did it give a blood pressure chart in here?
Yes, on page 464, or I'm sorry, 465. No, wait, hold on. 466.
Okay. So what's your question? Are you not understanding why that's a stage 1, or was it keyed wrong, or what?
No, I think I must just be looking at like an old one or something, because I had just Googled like blood pressure stages, and I just had a chart that I've been like, I printed off and I put it in my notebook, and I guess it's an old one because it has stage 1 as 130 to 139,
and stage 2 is 140.
I'm sorry, what?
And stage 2 is 140.
Yeah, and high. It says stage 2, 140 or higher.
Yeah, that is old.
Okay, good to know.
Those, yeah, in like, I want to say like 2003 or something, but it didn't go into effect until much later. And this chart right now is what we go on. So just to remember that, it's like they go up in increments of 20. And the old chart goes up on the systolic in increments of 10. Okay, like the first number. And the correct chart will go up in increments of 20, except for normal, which is less than 120. Oh, and less than 80. Even though we a lot of times when you're just talking to a person and they ask what normal blood pressure is, they're going to say 120 over 80. But technically, normal is less than 120 over less than 80. And when you hit 120 over 80, it's the very beginning of prehypertension and the new chart. But it's been around. I mean, we've used it for a while.
On student RDH, it gives that chart that has like what we were just talking about, but then it also has like something about the American Heart Association new guidelines that has like the normal, elevated, stage 1, stage 2, and then the hypertensive crisis. And those are different than what
did those say?
So the normal is the 120 over 80, but the elevated would be 120 to 129, and the systolic would be less than 80. Stage 1 would be a systolic of 130 to 139, dystolic of 80 to 89.
Yeah.
So
and then stage 2 would be
140 to over 90.
Yeah, that's the old. Yeah, that's an older chart, and sometimes they'll give you both. I have seen reviews that do have both the charts side by side, and but I'm pretty sure on boards that they're going to use the chart that we use now in clinic, and that is the normal prehypertensive, stage 1, stage 2, and hypertensive crisis. That's the one that you learned at in 101, is this one. The 120 and 140, 160. Anything else? Everybody understanding that? All right, so what I thought that I would do for this is I cannot just copy this down because it's copyright infringements for this, but I thought what I would do in January, I went to a dental hygiene board review in Chicago, and they went over, it was like 3 days, 8 to 5 of just being in lectures. It was a board review, and I don't know, there were probably 300 people in there, at least somewhere between 300 and 400. Many of them were students that they were flying in from around the northern area, and they were there to take their boards, but there were an awful lot of instructors there as well. And so, and Professor Tresner has taken this same course from the same people, but she took it, she might have been one of the first to take it. Maybe she and Professor Bowles a couple years ago. And so I finally went, and I thought what I would do is go over in their clinical. Now, they have a section, clinical dental hygiene, fluorides, and antimicrobials. And they are saying that at least a third of the questions on boards will come from this area. Now, you know, there were some instructors there and deans and whatever that were saying that they are responsible also for throwing questions into the mix as far as them being on boards. And so I don't know what to tell you. I mean, I don't know how accurate that it is. They're a pretty great group. It was an awesome seminar. I was excited for it and a little dreading it, because the same with you guys, it's just sitting there for 8 or 9 hours, 3 days in a row. I just was like this, but it was so interesting. It was just really interesting. We went through this entire book and wrote down notes. We had no guides or anything like that. We just kind of wrote down notes. So I thought that I would go through, I wish I could just make a copy, and they specifically said, please do not go home and make copies of this because it's copyrighted and whatever. But what I can do is verbally go over it. So I would, luckily this is going to be recorded, or you can get listen to it at a later point and get a piece of paper and kind of go over some of the things they talked about. Many of the headings and everything in here, but then would go back and say, I promise you there's going to be at least one of these questions on boards, I know. Okay, so I will point that out and you can write it down. They talked about, we're going to start with infection control. And it's just making sure, and I know you do already, that regulated biohazard waste needs to be disposed of properly. And examples of regulated biohazard waste are sharps, items, anything that drips blood and saliva, and hard and soft tissues that are removed from the mouth. So that is, but remember it says saturated. That's why we put the saturated gauze in those biohazard bags if they're absolutely saturated. Now, in researching this, Dr. Thurlow saw that, because at first we were putting anything with blood on it, you know, in there. And she said no, and showed us to where it needs to be saturated. So if you just have some bloody gauze, as long as it's dried and whatever, then it can go in the regular, I always, you know, scoop it up in my gloves and put one over the other. and throw it away in the trash so that they're not just laying there. I mean, I would never, I went by one of the, was putting some sharps actually in the sharp container and with the juniors, and saw just some bloodied gauze. It wasn't saturated, but just bloodied gauze in the trash can, just kind of laying on the top of the rest of the trash. And I thought, you know, they have just, I'm sure you remember, they have many things to learn and are so saturated right now with everything that they're going through that these things will take time to go back and just rehone. But we just don't throw bloody gauze by itself in the trash. You know, you kind of cover it with something, put it in a paper cup, etc. The safety data sheets, the SDS, which was formerly the MSDS, the Material Safety Data Sheets, from 1994. So what the only thing you need to know about that is that they said is that you need to review the SDS sheets of whatever that you're using. So we're able to tell you kind of a little bit about it, so you guys don't go in and I'm sure you've seen that SDS. Have you seen the SDS notebook? Anybody? Because it's like this. I mean, it's this big, like this, and like about that thick. It's hard to even open. It's got such big rings. So of course that you're not having to go in there and look at every one. But when you get a private practice, and the board answer would be that, of course, you are reading everything that you're using. And it's not a bad idea to do if you get into private practice and when you have a minute or two along the way of just kind of looking at things and getting in touch with everything that you're using. For instance, there is, I think we went over this in 101 a long time ago, but some people are very allergic to pine nuts. And there are, or were, even recently, prophy pastes that have pine nut in them. So it's if you were to have an allergic reaction to any kind of prophy paste, the bad would be on you. You know, that you didn't know. It's our responsibility to know what the ingredients of whatever we're putting in or on another person's body. Okay, so it's good to look at those. As far as the PPE, you're of course going to change it whenever it becomes wet, moist, and with every patient. They said that there could be possibly a question about wicked masks. And I don't know, have you gone over that, wicked masks?
No.
Okay. It's spelled W-I-C-K-E-D, just like wicked. And they consider a wicked mask something, now you'll die laughing, but this is the example they gave. Snot drips onto the mask from the inside. So let's say that you're the clinician, you have a mask on and you sneeze. And anytime the mask gets moist or a little wet, it's considered to be a wicked mask. And so it needs to be changed. You know about the gloves and eyewear, shields, and clothing. The purpose of the PPE is provide barrier to minimize the exposure to aerosols and splatter. Aerosol is invisible. Splatter or spatter is visible. And they made sure to make a differentiation between that. Aerosol is invisible airborne particles, and they remain there for a while. Spatter is visible airborne particles of blood or saliva, and they'll drop quickly to the floor because they're heavier, and on countertops, etc. And something else, barriers are not controlled by OSHA. I said make sure you know that. Any kind of barrier is not controlled by OSHA. Direct contact is directly touching infectious agents, saliva, or blood. Example would be the air and water syringe tip. For direct contact, indirect occurs through a contaminated object, such as your hand mirror. So then there's disinfectants, kill or inactivate most pathogenic microbes. But as you remember, disinfectants do not kill spores. So the qualities that we would want would be rapid, broad spectrum antimicrobials, bactericidals, fungicidals, tuberculocidals, and virucidals. They should be odorless if possible, easy to use, economical, fast acting, compatible with the environment and with all the surfaces you're putting it on. Has a residual effect, but it continues to work after it dries, which is why we leave everything wet, because it will continue to work after it's dried. So we don't wipe the chair back off, for instance. It needs to be EPA registered, non-toxic to touch or inhalation, and it needs to clean and disinfect. The types are chlorine-based compounds. They would be corrosive to metals. Cavicide with an iodophore. It can discolor some surfaces yellow. Phenols are water or alcohol based. It could leave a film or residue. Quaternary compounds are not corrosive, but they have a lower kill spectrum. They have very limited efficacy. OSHA says that glutaraldehyde should not be used as a surface disinfectant, only because of toxic effects of the fumes. And it's also corrosive. So they don't go for OSHA. Heat sensitive items and has to have a lid on it for 10 hours if you're going to put something and submerge it into a glutaraldehyde. Needs to be for 10 or more hours. So the levels of disinfectants, you have your high, intermediate, and low. You guys remember that? High is used in surgical areas, intermediate, dental offices. It must kill the tuberculosis organism. And low, generally used at home, not acceptable for use in a dental office. Sterilization, like in the autoclave, is going to kill all pathogens, including spores. Methods of sterilization, use heat or chemicals. They said to make a note that the boards usually will ask about at least one of those methods, whether it's chemical, dry heat, or steam. The spore test of each method, conditions, and considerations. Have you had anything about this? I know you had to do a chart for me in 101. Do you remember anything? You want me to go over?
Dry heat takes the longest, right?
Right. Very good. Chemical is where you have to have ventilation. Remember, that's the one that stinks, and you have to have proper ventilation in the area. It can damage rubber and plastic. It's recommended a minimum temperature of 273 degrees for 20 minutes. And the spore test for that is Geobacillus. It was formerly called just Bacillus. Do you have any kind of a sheet that goes over what the actual spore tests are for each of those?
There's some information about it in our review book.
Okay, so I would go over that. They said, actually, they put a note on here and they said, be sure that you view that chart, the chemical, dry, heat, and steam, a week before boards. You go over it again. So dry heat, I'll look in your, where's your, you have this, do you have Darby?
Yes.
Okay, and let me look in here. Trying to kind of hit more things that you're not already getting. Oh, okay. Okay, this chart that's in your Darby is pretty large. They suggest to only go over mainly chemical, dry heat, and steam. I'll make a note of that. I'll put together something for you so you can only have to go over that much. Okay. Dry heat is 340 Fahrenheit for an hour or 320 for 2 hours. It's recommended for metal instruments. You cannot put paper products in there. May damage rubber and plastic items. It's not recommended for any of your hand pieces. And the spore test is Bacillus atrophius or whatever, but I'll write this down for you and give you a copy or type it out. Steam, recommended minimum sterilization. It needs to be 250 degrees Fahrenheit for 30 minutes. It corrodes non-stainless steel instruments a little bit, or non-stainless, which would be carbon. It dulls your instruments and burrs a little bit. It's okay for some plastics, cotton rolls, gauze, cloth goods. Paper packages come out wet and tear. As we well know, they can come out wet and tear, and the spore test would be a geobacillus. So it's geo and bacillus, and then geobacillus again would be the spore test. Okay, you're going to clean the instruments in the ultrasonic cleaner. Avoid overloading the instruments in the autoclave, single layers. Using cassettes help that, and use proper ventilation. You can use a cassette or a wrap, plastic paper pouches, nylon clear tubing and paper. And then a note with big stars says external indicators are your tape or printed on packaging materials that change color. They only indicate when the instruments have been heat processed, not sterilized. So those indicator strips are only saying that the heat, it's reached the amount of heat that it needs to. Sterility is not guaranteed with an external indicator tape. So those things that would be like your masking tape that turns black diagonal marks, or external indicators would be those pink ovals that are on sterilization packages, and after they're sterilized, like they turn kind of blue or something, that is an external indicator. So that means that when that turns the right color, that you have reached the right amount of heat, but it's not completely sterile. So you do biological indicators. We have those, which we put in there for spore testing. You guys do that and put a biological spore testing, or actually, I think Chris may do that and then she comes and gets it out and puts it in a paper envelope and needs to mail that in. It determines if the sterilization cycle is reaching the proper temperature, time, and pressure. It needs to reach the right pressure to kill all organisms. The application of what I just went over, they said that to get, make sure you know some examples of regulated biohazard waste. Know each sterilization method, including time, temperature, and pressure. But they only show 3 of those, which I'm going to get to you. Identify the spore test used with each sterilization method, Geobacillus. And identify types of materials and instruments recommended with each sterilization method. In other words, pretty much know that chart. Okay, when you're assessing a patient, you'll be given the following on board case studies. You're going to be given a review of a patient's medical history and dental history, their vital signs, and some other areas that you need to review for questions that they would have. You will, you're gonna, when you review the dental histories, you're gonna classify the patient using the ASA guidelines. Let me take this phone off the hook. If there are any questions regarding the medical history, the answer will be contact the patient's physician prior to starting any treatment. I said they're going to have lots of different questions, and if you hear any question that has to do with their medical history, unless it is something like in the medical history, it says that they are, they just had a heart attack or whatever, you can point that out. But if they ask any other questions about it, and the answers will be, one of the multiple choice will be patients, get a hold of the patient's physician prior to starting any treatment, that's going to be the right one. Vital signs, you want to know the normal ranges. No, both blood pressure. Okay, it says no both. Sorry, my husband put 2 phones in this room. I think we were a call center. Hold on. Okay. And it does have a note in here that says no both blood pressure reading tables. And so that, it sounds like a lot, but it's not really as hard if you remember that the old one, and I'm talking, if you can get the first part of the, like the systolics, then a lot of times you can get the rest fairly easy. So the old one, there's only 10 in between each section, between pre-hypertensive and normal and stage 1, stage 2 on the systolic, and there's 20 differences on, I mean, 20 as the difference on the new.
Professor Ramos.
Yeah.
I think that's actually backwards. The old one has 20 in between, and the new 2017 guidelines have 10 in between. And then our candidate guide for the board exam says to know the 2017 blood pressure guidelines that only goes up by 10.
Really?
Yeah, because when Alexis had mentioned it about the question in our book, I had also gotten that question wrong. So I went to the American Heart Association's website, and they had new guidelines from 2017 that go up by 10. So then
You're right. You're 100% right. Here it is. I thought it was the old one. Have we been using that new one? I mean, it has new classification for 2017 plus. Oh, I'm so sorry, guys. I so thought that was different. Well, see, you know more than you think you do. Okay, so the old one was by 20. The new one is by 10. Wow. There's a whole lot more people that are going to be hypertensive, right? Hypertensive crisis. Oh, you knew. Okay, reverse that. Thank you for pointing that out. The old one is 120, but whatever, it's the difference of 20 on the systolics. Now the new one, and what you mentioned a third thing. You mentioned the old one, the new one, and what?
I looked up the candidate guide for our board exam, our written exam, and it says that the 2020 board exam will reflect the new guidelines for blood pressure.
Okay. All right. Okay.
So I just wanted to clear that up or throw that out there.
Yeah, I'm so glad you did. Well, I asked Dr. Thurlow, remember at the beginning of the year, and she said, no, we've been using the new ones for forever. We haven't. Have you guys been using the new ones in the clinic with your patients? No, see, didn't either. To get on that. That's why I thought for sure it was the other way around. Okay, thank you. Will give me something else to talk to her about. Certainly it is not in Wilkins. We just got a brand new, it's usually the Bible of all that stuff, and we just got a new textbook. It's not in there either. But anyway, don't waste let me look up about that and why we're not doing that. Okay. So you didn't see anywhere, they didn't change pulse and respiration or anything, did they?
I don't think so, but I could look. I have the candidate guide pulled up here. Just give me a second.
Okay.
No, the candidate guide doesn't say anything about a change in respiration or pulse. It just talks about the blood pressure.
Okay. Just got a note and it says to say it was in your 12th, the 12th edition. Because I don't think that's what it said in. Weird. See, now I've got the 13th edition, and it doesn't list that. It lists it as 20 in between. Stage 1 hypertension, 140 to 159. Stage 2, over 160. But I have your edition too. I will definitely get on that. But whatever you did before, whatever, the point is that they're saying that on boards, you're going to be using the 10 in between 2017 guide. Good to know. Okay. Other things that are important to review about this, I said, is review if the patient is under the care of a physician, if the patient has been hospitalized within the past 5 years and reason for hospitalization, current medications, if the patient smokes or uses tobacco, if the patient is pregnant, medical, dental, and social histories, chief complaint, if any, always address that first, and you guys know that. Okay, it says look at board questions in detail on African Americans and the increase in blood pressure. Yes. Look at their social history. It says the chief complaint is first or chief request to show the patient you're recognizing them, and the patient will in turn be more compliant with what you're doing, given the age and gender of the patient. They said on boards there's at least one question about vitals, if not a few more, and then they move on. They said restorations will not be marked. You will look at films for the black GB Black's restorations and carries. You remember GB Black's, like class 1, like a class 5 is down at the cervical. Do you remember all that, or have a chart of it? Do you want a chart of it? Okay. You'll need to give examples of patient conditions that fall into each ASA classification, 1, 2, 3, and 4. Recall normal ranges of vital signs, especially for case-based portion of the exam. So I take it that I think they said there may be 1 or 2 questions, like asking what the blood pressure is of a stage 1 or stage 2 or something, but that most of your questions about blood pressure are going to come in the case studies. And then GB Blacks, I'll get that together. Actually, I remember, I don't know if you still have your sheet of paper that has GB Blacks on it. It's about like this, and it has pictures of the tooth and exactly where those restorations or cavities are on stage 1, stage 2, and all that. And you got another one in radiology? Awesome. Okay. So they have missing teeth, extracted teeth. You're going to mark with an X. You know that. Periodontal chart. They may show 1 or 2. CPCs. Not sure I know what a CPC is. But they said when you get the periodontal chart, you glance at it and go back later. Don't spend a lot of time on it. They could show one or two, a prior or a current appointment of a periodontal chart and ask you questions about that. Furcations are marked like a triangle in there. I don't know if you see. Okay, so if it's, I don't know if you can see this. Okay, so the very top one, if it's like an early furcation, but you can't get into it, but you just go, it's like the top of a triangle that doesn't have the bottom on it. That second one, it should be more even triangle. So that would be one that you could put your probe into, but you may just go slightly inside. The bottom one is if you can go all the way through, and then that would be how it would be marked if they would take the triangle and fill it all in. They said when you're looking at charts on boards, they said to look at the photo, not just the film, when you're looking at recession. When you assess furcations, you always use a neighbor's probe. You guys know how to spell that, neighbor's probe? Okay, and know what that is because we don't use them, but it's the curved probe. And evaluate furcation before recommending oral physiotherapy aids. Said you need to know how open that the furcation is before you ever recommend oral aids. And there's a big stars, a couple big stars by that, as far as a question that might be asked that way. Mobility. They have a chart on mobility, which would be just like your chart that you got from me, but they have N is a normal in mobility. A 1, it involves slightly horizontal mobility. It would go back and forth if you put your finger on a, like you shouldn't use your finger actually on mobility. You use an instrument and put that on top of the tooth because you'll get too inaccurate. You'll think something's moving when you just put your finger on it with a glove. So you need to have something stable, and which would be kind of the back of an instrument or the handle of an instrument. So you could take your mirror because it doesn't have a sharp edge on the end of it that you're putting close to the tongue and everything. So you'll take your maybe your mirror handle, put it on the tooth, and if it goes, you know, if you're putting it here, and if it goes back and forth this way, horizontal, then slightly, it would be a 1. They could use the number 1 or the Roman numeral 1, either or. 2 or a Roman numeral 2 would be, it moves moderately horizontal, greater than 1 millimeter, would be a 2. And so it's going to move greater, but still not vertically, not up and down. A 3 is going to involve severe mobility with possible combined horizontal and vertical movement, which means it's going to go up and down like this. And that. Refer to intraoral photographs and or radiographs when it comes to bridges, implants, root canals, and restorations. They said it's an absolute must. Do not just view one or the other. It can be tricky. You have to look at both the films and the photos. So they want you to be able to identify furcations on a dental chart, on radiographs and photographs. Also with GB Black's classification of restorations and caries from photos and radiographs. On your intraoral, your class of occlusion, they said know these for pictures and from films, that they may show you films of people biting down and just show you the film of that and ask you what kind of occlusion that is. And they said on boards, if there's no molars, definitely use the canine relationship. Don't just say there is none, like we do in the, and that's also different per dentist. Some private practices will just say don't, if they don't have molars, I don't want an occlusion. And some private practices will definitely want you to follow the canine relationship if they don't have molars. The closer you get to the specialty of orthodontics, now they would have to have it exactly. But general practitioners, sometimes if they don't have the molar relationship, they don't carry it on. It says in here that you're going to have a dry erase board to draw the verbiage description. So when they're saying, you know, the verbiage description of being maxillary canine occludes with the distal half of the mandibular canine and mesial half of the mandibular first premolar, it's such a mouthful. And that while you're taking the test, you'll have a dry erase board so that you can draw what that sentence is saying. And then you can be able to tell whether it's right or wrong. Have you heard that before, that you'll have a dry erase board? Oh, good. Okay, so one of the things that they have mentioned to make sure that you know on a class 2 division 1, first of all, that's retrognathic. Remember, because we're gonna, for this description, we're gonna go by the mandible. When the mandible protrudes a little bit and the maxillary goes out a little bit, that's where you can have your buck teeth, and they can either kind of jet out or be straight, or they can be a class 2, which would, the front teeth would retrude back this way. And to know that a class 2 division 1 is retrognathic, and that a class 3, it's when your jaw is pushed forward, so it's prognathic. One thing that can produce the class 2 division 1, the retrognathic, is thumb sucking and thrust. So then it goes through all that. I won't go through all of those. You guys have this in a million different places. All of the mesognathic, you know, class 1, and where the molar and the canine relationship is. Remember that malocclusion includes overbite and overjet. Overbite is vertical overlap of the maxillary incisors to the mandibular incisors. And overjet is the horizontal distance between the linguals and the maxillary and anterior incisors. We use a probe to measure the overjet. We don't use that to measure overbite. On overbite, we just say it's slight, moderate, or severe. Open bite, cross bite, midline shift, or deviation. When you have a midline shift of the maxillary incisors does not align with the midline of the mandibular incisors. So that's taking the in between your 8 and 9 and in between 24 and 25 when they bite down like this. You can't just follow that midline all the way down. If you could, between the maxillary and the mandibular, of course, that would be perfect. Their alignment is perfect. But if the mandible moves, the maxillary does not, okay? So that bone is in place and the mandible is going to move. So if the mandible is slightly to the right, you would say it's deviated slightly to the right or deviated slightly to the left, which if you took a pencil and drew that line, it would now look like a step, one way or the other. Edge to edge, incisal edges are together like this. End to end, cusp to cusp of the posterior teeth. Different kinds of calculus. The mineralized plaque provides an irritant to the gingiva. On calculus, for the type supragingival, nutrient source is saliva. The nutrient source for subgingival is crevicular fluid and inflammatory exudate. The most calculus is distal of the first molar, mesial of the second on the facial. Calculus detecting explorers are the 11-12 ODU and the pigtail for posteriors, and an Orban type for anteriors and cervical third of posterior teeth. Those will be your 17, number 17 explorers. Always want to dry the teeth with compressed air. Use radiographs for when you're looking for proximal decay, which you know. Then they jump to stains. So extrinsic stain is removable if it's exogenous. Remember, genus means it begins at, and ex means outside of the body, and ongenous would mean it begins inside of the body. So any kind of stain that is outside of the body is removable, and it stays removable until the stain goes into a demineralized area. And when a stain kind of goes into the demineralized area, it often becomes invisible. Some causes include certain bacteria or other sources such as food, beverages, tobacco, just to name a few. The types of extrinsic exogenous would be your black line stain, which is likened to calculus in trying to get it off. Black line is gram-positive bacteria, basically because it's supra. It's not down in the pocket. Typically located on the cervical thirds of facials and linguals on your posteriors. Brown, tea, coffee, fruit juices, red wine, and poor oral hygiene. Dark brown and black associated with tobacco use. Orange is chromogenic bacteria in the plaque. It's associated with poor oral hygiene. Orange is typically located on the anterior teeth. And it's orange chromogenic means, it picks up, the stain picks up the color of the foods and drink that you're consuming. Yellow, brown, and brown can be associated with chlorhexidine or stannous fluoride. And what makes the stain in stannous fluoride is the reaction of the tin oxide. When you have stannous fluoride, it's made out of tin oxide, and that is what is the, it has a tin ion in it, and is responsible for the staining. Green is associated, once again, it's like orange, with poor oral hygiene, except for green is chromogenic bacteria, fungi, and gingival hemorrhaging. So anytime that there's been some bleeding up in the gingiva and then it dries but it hasn't actually gone away, it can give a greenish hue to it. If the stain is located on cementum, your choice for removal will always be instrumentation. Big point to know. Choice for removal of stain on cementum is not Plicavitron. So intrinsic and endogenous is not removable because it's inside. Possible causes usually include the pulp necrosis, so death of the pulp, and then all its byproducts are dying, and it kind of turns different colors. It can kind of turn maroonish and then brownish, maybe even a little greenish. Internal resorption, if your roots are resorbing and you're not sure why. Excessive systemic fluoride. So this is someone who maybe drinks have fluoride in their water, and they take fluoride pills, and that's going on inside. It's just fluoride, fluoride, fluoride. Could give a stain. And tetracycline use only during tooth development. So when do the teeth start developing, the permanent teeth? It's at birth. So at birth, your permanent teeth are going to start to develop. Beetle stain. They have it that on boards, it's from, we learned that it was from Asian, Vietnamese background. And they're saying that on boards, it's going to be Burmese patients. B-U-R-M-E-S-E, Burmese. Is beetle nut legal in the United States? And they said, yes, it is. They said, make sure that you know that nutrient source for super and sub. Identify calculus detecting explorers and where they're used. Recognize calculus on radiographs and photographs, and stain as well, and know their origin. So there's a big, huge asterisk and everything around dental caries. That you need to know that demineralization is a process occurs when the pH drops below 4.5 to 5.5 for enamel, and between 6.0 and 6.7 for cementum. These are known as the critical pH levels. So if you get a question that says the critical pH level for enamel is, you're going to know it's the 4.5 to 5.5 pH. and is also when demineralizing will start. Okay, early childhood caries. You should have, they may show you a picture and ask you what it is, and the answer will be early childhood caries. And I don't know if that's the picture they show of rampant caries, would be something that I might think of as in regards to early childhood. Fluorides, the role in the caries process. Fluoride interferes with the bacterial metabolism. In really high concentrations of professional application, fluoride is bactericidal. It is destructive to bacteria in high concentrations from the dental office application. In low concentrations, this would be your daily at-home application, like in your toothpastes, etc. It's a bacteriostatic, which means it inhibits the growth or multiplication of bacteria. It has substantivity. You guys remember what substantivity means? Okay, so it's the ability to bind to the pellicle, plaque, and tooth surface and be released over time with a retention of potency. Okay, they always say things. So what it is, it's something that is sticky and has the potential to hang there for a while instead of just being like your fluoride varnish has high substantivity because it can go through plaque, and it goes through the biofilm, it goes through the pellicle, and it can get down into the teeth, even if the tooth isn't cleaned properly, and it stays there for a while. That's substantivity. It has high substantivity. Something that has low substantivity would be something that like mouthwash. Okay, so you swish it around, you hope that it's doing some good, but it doesn't just linger, it doesn't stay on your teeth for a long time. It's going to wear off very quickly. So that would have low substantivity. So it's the ability, if you see anything about binding to the pellicle and plaque and tooth surfaces and released over a period of time, and it retains its potency during all that time, that's substantivity. Do not need to polish the teeth prior to application. And there's 3 stars by that, so they must ask a question about that. So just remember, you do not need to polish the teeth prior to application of fluoride. We just do because it has better. It just gets on there better, but you wouldn't have to because the fluoride will go through all of that, which few things do. Fluoride therapy methods of fluoridation include pre-eruptive fluoride and post-eruptive fluoride. So how you get pre-eruptive fluoride is systemically, because before your teeth are erupting, you're getting everything through your system, you know, or even when the tooth is baby teeth are first forming, it's all systemic through the mother. Okay, then it's through the child. After your teeth have erupted, which is post-eruptive, then you need to do some type of a topical application of fluoride. So topical post-eruptive would be water, toothpaste, rinses, fluoride treatment. All of that would be post-eruptive. Pre-eruptive would be water, supplements, foods that you could get fluoride through into your actual system. Characteristics of pre-eruptive: it circulates in the bloodstream and it's incorporated into the enamel of the developing teeth. It's rapidly absorbed in the stomach and small intestines. Any amount that is not used of fluoride is systemic fluoride. It's excreted through the kidneys. Examples of systemic fluoride: water fluoridation. That's a great systemic. We have to drink the water that has the fluoride in before we can get any good out of it. Water fluoridation is the adjustment of the fluoride ion content of your water supply, domestic water supply. And they bring it up to an optimum concentration, and which can provide protection, the most protection you can get against dental caries, and also with the minimal possibility of producing enamel fluorosis. Because remember those ugly pictures of that really heavy enamel fluorosis. So they're always having to figure, they have to figure out what is the percentage that we can use that will give the maximum benefits to the teeth and not produce fluorosis. Okay, so the most cost-effective and efficient method of delivering fluoride to a community is always going to be the water fluoridation. It's the cheapest method and the most effective method. Average cost is 13 cents up to $5.48 a person per year, depending on the size of the community. If you have a really large community, you're going to have even lower costs. Very small community, you're going to have a little higher cost. The optimum fluoride level, I know you know this, is 0.7 parts per million milligrams to liters. Only in 2011, they changed to 0.7. Before that, they had the optimum level ranged depending on the area from 0.7 all the way up to 1.2, depending, and that depended upon the climate. The optimum level, which would be 1 part per million, you have all 4 seasons. The warmer climate, you have a lower concentration level, like 0.7, and the colder climate, you have a higher concentration, more like 1.2. So way back, they had their first adjustment in 2011, and it was the first adjustment of fluoride amounts since 1962 due to fluorosis. They want you to know about the 2 different agencies: EPA, Environment Protection Agency. It monitors the concentration level in community drinking water. And the FDA sets the limits in bottled water. So EPA monitors concentration level in community water, and FDA are going to set those same limits, but in bottled water. Compounds used to fluoridate water include, and I've seen this in several different books, they're going to be sodium fluoride, sodium silicofluoride, hydrofluorosilicic acid. I'll write that too. You guys probably have that from another book. If you do, let me know. So defluoridation. The EPA mandates defluoridation if the fluoride level in the community water source exceeds 4 milligrams of fluoride, 4 milligrams of fluoride of water. The EPA recommends defluoridation if the fluoride level is between 2 and 4 milligrams. Dietary supplements are recommended for children who live in areas with inadequate water fluoridation. They're not recommended for pregnant women. And they're not recommended, it's just a waste of money. Somebody may talk a new mother into getting that as being so helpful for the child, but they're just taking it for no reason, because the permanent teeth don't even form till birth. So taking it prior to the child's birth isn't going to do a thing. So supplemental fluoride dosage schedule. There's at least one question they said from this table, if not a few more. The American Dental Association becomes familiar with the table. Okay, wait a minute. Okay, this table was made in 1994, but we still use it. And that's the table that's, I know it's in your text. It's the supplemental fluoride, where they give the age, birth to 6 months, 6 months to 3 years, 3 to 6 years, and 6 to 16 years. And then it gives the concentration of fluoride ion in the drinking water. And so that's something too that I probably would look at right before the boards, once again. Okay, so the ADA Council on Scientific Affairs is who came up with this supplemental fluoride dosage schedule. Foods, you can get it from fluoride from foods. Tea and fish contain large amounts of fluoride. I try to remember that. Tea and fish. And out of tea and fish, I believe fish is the highest. But let me get back to you on that. Okay, professionally applied post-eruptive, like your topical fluoride, would be your applied topical fluorides. The types include sodium, acidulated phosphate, and stannous fluoride, stannous sodium fluoride. So sodium fluoride, it's used in the presence of tooth-colored and porcelain restorations. So no amalgams. The application, the tray method, is the most effective delivery system for anybody with rampant caries, mostly their children. Rampant caries, best would be the tray. 4-minute application for maximum efficacy, so you'd leave them in that tray for 4 minutes. 1-minute applications are not recommended due to lack of efficacy data. That's what they used to have us doing for a while. They all came out and said that you could put the gel in a tray and they would just have to have it there for 1 minute. And they're saying it really doesn't do all that much if it's there 1 minute. 4 minutes is the best. Okay, the greatest uptake is within the first minute, but it needs to be left there. Instruct the patient not to eat, drink, or smoke for 30 minutes post-application. This way is very recommended for bulimics. So that is all about sodium fluoride. Sodium fluoride varnish. Let's talk about that. Contains 5% sodium fluoride. It's used for desensitizing exposed roots and caries. You use 0.3 to 0.5 of a milliliter per application, which is very small volume, very low dose. Retain for 24 to 48 hours, during which time the fluoride is released. for reaction with the underlying enamel. So it has a high degree of substantivity because it can hang there for 24 hours, up to 48. So recommended applications are repeated 2 to 4 times a year, more effective in caries reduction than traditional professional topical fluorides. It has a 14% more effective than a gel. Effective for use on infants and small children with significantly less fluoride ingested than with APF gel, which is also really easy application. You don't give this to your patient to take home and do it. It's not for home use. It is for professional application only. Acidulated phosphate fluoride. It's contraindicated in the presence of tooth-colored restorations in porcelain. Acid in the fluoride etches the glass components in a restoration, causing surface roughening and pitting. You can paint it on with a cotton tip applicator. They have a gel-like form, or they have foam. Okay, and stannous fluoride. And stannous fluoride is an unstable solution. It needs to be mixed right before you use it. It does not have a good taste. It's metallic due to a tin ion in the compound. The stains demineralized areas and margins of tooth-colored restorations due to the reaction of the fluoride tin ion in the compound. So sometimes you will see that at the very margin of a tooth-colored restoration, you're going to see a lot of stain. And stannous fluoride can sometimes cause possible gingival sloughing of the insides of the cheeks. And it doesn't always cause it, but it could cause it. So I would also look at the table of sodium and sodium varnish acidulated. I'll put that table. I think you have it already, the fluoride table. So they want you to remember how this is applied to boards to recall adverse reactions and indications for use for each type of fluoride. Determine the proper fluoride concentration percentages. Know the compounds used to fluoridate the community water system. So note, if a patient has hypersensitivity due to recession, you always want to use the fluoride varnish before they leave. Self-applied topicals, it provides additional form of frequent low concentration fluoride. It's trying to promote remineralization. It includes rinses, dentrifices. So our rinse needs to contain at least 0.05% sodium fluoride daily. Dentrifices, depending on the fluoride compound, they can contain anywhere from 400 to 1,500 parts per million. So let's talk about the toxic effect of fluoride. This could be used in a case study question. They said, don't be surprised if you hear one about fluoride safeties. It's children 6 years of age and under should not use fluoride rinses for the fear of swallowing it. It's a pea-sized amount of toothpaste when brushing is what they should use only. Okay, some of you have to go. I will keep going through this and just keep recording it since we got a late start. Okay.
Professor Ramos,
Ah,
you said children under 6 should get no fluoride at all, or
they're saying they should not use, I believe it's fluoride rinses.
okay, thank you.
Just fluoride rinses, because children 3 years old and under can have varnish. But we didn't always have varnish. I remember when we had rinses and fluoride, when it was foam and like in a tray, and we couldn't give those to anyone under 6 because they have a tendency to swallow it. But when fluoride varnish came out, then the board questions had to change because they most certainly can be given fluoride varnish. Okay, so instruct your patients how to correctly use the self-applied topical fluoride products if they have any. We don't really like to give that, but and always use a pea-sized amount of toothpaste for children when brushing, when it has fluoride in it, or I think really any toothpaste. And it's for fear of swallowing. Know the potential toxicity and be prepared to administer emergency procedures. You can even open up talking about toothbrushing with your patient by a goodie bag with a toothbrush in it, as you all know. The certainly lethal dose, which is acronym would be caps, all caps, CLD, or certainly lethal dose. Well, I wonder if it should be certain. Anyway, the amount of drug likely to cause death if not intercepted by antidotal, an antidote therapy. Safely tolerant dose is acronyms capital S, capital T, capital D. Safely tolerated dose. A safely tolerated dose is about 1/4 of the certainly lethal dose. Whatever. Okay, acute fluoride toxicity. Symptoms begin within 30 minutes of ingestion and may persist for as long as 24 hours. They're going to have stomach issues. Fluoride in the stomach reacts with the hydrochloric acid in your stomach to form hydrofluoric acid, and that causes irritation to the stomach lining. And it's going to result in nausea, vomiting, and diarrhea. Abdominal pain, increased salivation and thirst. And a systemic involvement results, all that was from the stomach from ingesting it, but a systemic involvement is the symptoms of hypocalcemia, not making enough calcium, hyperreflexia, which is in convulsions, paresthesia, cardiac failure, or even respiratory paralysis is possible. Okay, they said typically you need to know that when you have the emergency treatment for too much fluoride ingestment, if it's just under 5 milligrams, it's milk of magnesia. That's going to bind the fluoride. It's a binding fluoride agent. So milk of magnesia, when it goes in, binds to all that fluoride and helps kind of, soak it up, take it in. It's under or less than 5 milligrams per kilogram. A toxic dose is more than 5 milligrams per kilogram. It's going to induce emesis. Emesis, E-M-E-S-I-S, if you remember, is vomiting. So they may just say induce emesis. You need to know that vocabulary. Over 5 milligrams per kilogram is considered a toxic dose. You need to seek medical treatment immediately. If you get a lethal dose of ingested fluoride, would be over 15 milligrams per kilogram. And you need to get them to the hospital stat. You call 911, you go to the hospital, you get them there, something. They need to induce the vomiting on this. And they need to have their heart monitored while this is going on. So it says, well, what to know about this? It says, know that table. Determine the emergency treatment for a given amount of fluoride ingested, what you can do. And you need to know the symptoms for acute toxicity. So chronic fluoride toxicity. They have something called skeletal fluorosis. It's the results after long-term exposure, like 10 plus years, of water containing 8 to 10 parts per million of fluoride. Long-term exposure, the picture that we were shown of this guy, the picture of the legs, his legs were super skinny. I mean, just bone and malformed. They're just not formed correctly. Dental fluorosis is a hypomineralization, so it's less than normal mineralizing, which means less than normal enamel. It's the mineralizing of the enamel. It results from excessive ingestion of fluoride of 2 parts per million and over 2 parts per million during amelogenesis, typically between ages 1 and 4 years old. Slight to moderate is more of a browning, and the severe will be the pitted brown and white, and they'll have you look at pictures of those side by side and kind of maybe have a question or two with having you put what's severe and what's slight or moderate. Auxiliary aids, toothbrushes, power assisted. Indications for use includes children, mentally challenged, physically as well, elderly, arthritic patients, poorly motivated individuals, or implant care. So they made a note to put on a patient with arthritis, you can take a tennis ball because they have a hard way to their joints and to especially rheumatoid arthritis, and it hurts to bend the joints. So you can get a tennis ball and split open a little top, stick a toothbrush in big enough for just a toothbrush to go in, and then they can hold on to that big tennis ball and help them brush. Poorly motivated individuals, and implant care. So you have power assisted. Toothbrushes are really for that group I just mentioned, although they can use manual too. But they're usually children, elderly, arthritic patients, poorly motivated, and implant patients usually benefit from the power toothbrushes a little bit more. Toothbrushing methods. You want a modified stroke, completes the remaining facial lingual surfaces. You have the Bass toothbrushing. You remember that, angles, bristles 45 degrees toward the apex at the gingival margin, 1/3 of the margin. And that will place those bristles slightly into the periosulcus, into the pocket. And then you vibrate around and roll it back out. And that's the most popular. The Stillman are when they're angled at 45 degrees, but your angle is, you're looking at more of the background of that picture. You are looking past, going forward. You're going to, you have angled the bristles 45 toward the apex of the tooth with at least half of the bristles. You place on the tooth, the other half on the gingiva, and phones position bristles perpendicular to the crowns of teeth. Brush in a circular motion, always. Charter. Place the bristles to 45 degrees towards the occlusal and incisal plane. Move the bristles in small little roundish rotary motions, keeping in contact with the gingival margin. Flossing. You want to start as soon as contacts are evident, approximately 2 years old for a child. You want to start them where they're deciduous. Hold on one second. Molars. So that's their baby teeth, molars. Additional oral physiotherapy aids. An interdental brush is used for open embrasures. A perio holder is best used for exposed class 4 furcations. Fixed prosthesis, such as under fixed partial dentures, pontics, or crowded anterior teeth, and ortho appliances. A toothpick holder, or what we call a perio aid. Used for, you can use them for exposed class 4 furcations. Interdental cleanings, concave proximal surfaces, gingival margins above an ortho appointment on the tooth or ortho appliance. Wedge stimulators used in interdental areas with exposed root surfaces or recession, usually made out of birch wood, or there's some other wood that's made out of, might be orange wood. Floss holder, those who are physically challenged and caregivers providing oral hygiene care. Tufted floss is under pontics or bridges or ortho appliances. An oral irrigator disrupts loosely adhered plaque and flushes the debris and food particles around the ortho appliances. Application to your boards. We said review dental charting and photos for furcations, overlap teeth, and fixed prosthesis, as well as other oral conditions, to determine the most appropriate oral home care product or physiotherapy aid, they're calling it, to recommend. So in dentrifices, you need to know the active ingredient And the active ingredient is the therapeutic part of the product. So the therapeutic active ingredient in toothpaste for caries is fluoride. For tartar control, you need to pick a toothpaste that has pyrophosphates in them. Then you have anti-hypersensitivity. If you have a lot of toothpaste up and down the aisles to look through, and you may have a lot of different brands that say sensitivity on them, but all they have to do is put a little less grit in one product over another product, maybe even in their own line, and they are allowed to call that particular one that it deals with it's anti-hypersensitivity toothpaste. So these are the things that you can write down on a piece of paper and give to your patient. And you can say, it doesn't matter, go find a toothpaste. You can mention, I know Sensodyne has a toothpaste like I'm getting rid with potassium nitrate in it. And potassium nitrate is the active ingredient in a dentifrice to work around a place or a tooth that is hypersensitive. If that product that they are looking at doesn't have one of these 3 products in it, it's not telling the truth. It's not a true anti-hypersensitive product. So potassium nitrate, strontium, I'm not sure, chloride, and sodium citrate. I'll write those down. Antibacterial. If you want a toothpaste with antibacterial, you need to make sure that it has triclosan in it. That's the active ingredient. If you want a toothpaste that has whitening in it, this is where they can really get you with what seems like to be false advertising. There will be so many different brands that will say whitening, whitening, whitening. And the normal Joe out here thinks if you're talking about whitening, you're talking about bleach being in there. And there's an awful lot of whitening toothpaste that do not have bleach in them. So they can say we're whitening it a little bit more than it was before, you brushed or polished. And that's good enough for the law. So it has to have either carbamide peroxide or hydrogen peroxide in it to truly be whitening. Don't waste your money. Application to the boards. Okay, debridements. This is where we're going to get into, there's not much more on this. This is where we're going to get into the instruments. And I can stop here. Kind of gonna go through this more when we do perio. I just want to go over a little bit of polishing with a rubber cup. What is the indication for use of polishing with a rubber cup? It removes extrinsic stain not accomplished with hand scaling or with toothbrush or toothpaste. But you're on stain, you're always the correct answer is to always try your instrument first. So you want to use very light and consistent pressure. Considerations for use. You're going to avoid polishing in the presence of, if the patient has xerostomia really badly, dry mouth, you're not going to want to. Demineralized areas or dental decay. If the patient has tooth sensitivity. Newly erupted teeth, you do not want to polish. I hope you remember that. Severe gingivitis, it's going to irritate the free gingiva that's already so inflamed that most of the time it can hurt. So you do not want to worsen it. Exposed root surfaces, try to avoid those. Respiratory conditions like asthma, emphysema, cystic fibrosis. Air polishing is slurry formed by forced air, water, and powder, sodium bicarbonate, aluminum trihydroxide, glycine, calcium carbonate, or calcium sodium phosphosilicate. Indications for use of air polishing. If you're really having a hard time getting that stain and biofilm off. Root detoxification performed if it's performed by a periodontist, like right before, if he's doing a flap or right before some type of surgery. Before sealant protection, before you do sealants, sometimes dentists like to have their hygienist blow all that air on the occlusal surface of the tooth to really get down in there and polish it with that force, because it's almost like a power washer on the sidewalk. And so you want to really get that clean. I don't know if we're allowed to use an air polisher in the clinic yet. Let me find that out. Because it's going to throw a little bit more as you, well, I don't know, more or less. Maybe if you wear an N95, but let me find out. Question came up on if we could use it in the clinic now. And I'm not sure. I've been gone for 2 weeks. I'm not sure what. Yeah, I think you all should be able to try one before you leave. Let's just hope that we'll see what we can do. Did we do that for your class in 101 or 102?
You guys, like, it wasn't working that day, but you showed us it, but it wasn't actually working.
I think I remember that all of a sudden. Yeah. Oh, darn, I'd love to show you guys that on pennies and stuff. Okay, I'll find out. Indications for the air polisher would be stain and biofilm removal, root detoxification if it's performed by, like I said, the periodontist, sealant preparation, or soft debris removal around ortho appliances. It's great for that. Contraindications. Someone that has a sodium restricted diet or because they have high blood pressure. They do make a sodium free formula for that, but you would have to make sure and go get it or order it in your private practice. You don't want to use that for people who are sodium restricted diets because of really, really high blood pressure. If they have spongy gingiva, like is in gingivitis, really bad case. Okay, so what my note is that I made on this with a couple stars is it says, if they ask a question about the contraindication of use of the air polisher on spongy gingiva, you're going to assume the question is about sodium bicarbonate and not sodium-free powder. So it may not say sodium-free powder or sodium. In fact, it probably doesn't. So unless they would say sodium-free powder in your board question, assume they're only talking about sodium bicarbonate. Okay, if they have respiratory conditions, no. Restoration materials, such as glass ionomers or composites. Porcelain veneers and luting agents, you don't want it, you just skip over those in the mouth is what you do. Exposed root surfaces, avoid prolonged use. So different books will say different things. They'll say never polish, or use that on an exposed root surfaces, but there's some exposed root surfaces that I have definitely used it on, and it has done very well. And especially those root surfaces of someone who has a lot of recession. Maybe, 5-7 millimeters of just recession down the tooth, and the secondary dentin has already formed. So this is like in your elderly, so that those roots are already pretty smooth and shiny, because the cementum has long gone. And definitely, and if they have stain on there, I would definitely use that. But if it looks like there's the cementum is still intact, or you don't want to, you want to try to skip over the roots and try to remove the stain with your instrument if at all possible. But if you are going to use it, avoid prolonged use of it, is what they're saying here. Contraindication is an immunocompromised person. It can increase their infections they are, because of it being so aerosol. And patients taking potassium, antidiuretics, or who are on steroid therapy. See, and I don't remember that being brought up in Wilkins. Maybe it was, but I'm not remembering that part. So when you're going to be air polishing, once again, you need to review their medical history. They said that the pulp vitality testing, it's under auxiliary services. And they said most of the time it is not on anything about the pulp vitality test, but it does come up every once in a while. So they just have a short little blurb about pulp vitality tests, because I know they have different kinds. They're saying that you would briefly explain the procedure to the patient, which you're supposed to do on every procedure. You would dry the teeth off and isolate them with cotton rolls so the tooth stays dry. You're going to apply a little bit of toothpaste, which works as a conducting agent, to the tip of the tester. So you put it on the tip of the tester like this. Apply the tester tip to the tooth in question, and then to another tooth, and do not place on the same tooth more than twice. So you're going to test the pulp in this, in 24, and then you're going to be moved to 25, and you're going to test that. It says, do not place on the same tooth more than twice. You put it on the middle to gingival third with absolutely no pressure, and avoid contact with the soft tissue or any metal restorations. So how is everything I just said applicable to your boards? It says identify indications and contraindications to rubber cut and air polishing, as well as ultrasonic scalers. The rest of this I will go on in, have a few more pages. Have a few more pages now. They said, I am going to show you this, if you can see it. They said that you're going to be given a film and a chart, restoration chart that you can also put perio numbers on. And they're going to want you to do like X out the missing teeth, and to be able to point out crowding anteriors, or 5 and 6 millimeters of furcations. So it looks like they're going to give you something. Oh, I don't think you can see that very well. Like that. Then the whole chart. And then a film. And see if you can pull out where the crowding and all of that is. I think, once again, if you are seeing pictures of classifications of occlusion, if the mesial buccal cusp of the maxillary first molar is a little in front or a little in back of where it's supposed to be at the buccal groove of the mandibular, don't automatically jump to a different class, because remember that if that cusp tip isn't directly fitting into that groove right there of the mandibular, and it's a little before or a little after, it has to be by the width of one of their premolars. So look at one of their premolars and see, has this moved the width of a premolar in front or in back before you would call it like a class 2 or a class 3. So if it's under the width of a premolar, you're going to call that a class 1, even though it's not right there, if that makes sense. So they have a question in here. Air polishing is not recommended for this patient. Like this is a 2-sentence question of truth or false. It says that air polishing is not recommended for this patient. Air polishing is contraindicated on patients with hypertension. The answer would be true, because you've got to think if they have wild hypertension, is what they may not say that, but they may not say it has light or mild hypertension. But somebody with hypertension, just assume that they're talking about like the kind of an uncontrollable point, unless they tell you otherwise. So the answer to both of those is that yes, both statements are true. So the aid that is best to recommend for a patient whose anterior teeth have a diastema in between would be an N-tuft brush. They're going to have questions on there that like this. The distal of the mesial buccal root of tooth number 2 requires root planing. Which Gracie curette is used to instrument this area? All right, so they're talking about the distal part of the mesial buccal root of 2 requires root planing. And so the answer to that question is the 1314. But she said, expect those kinds of questions. Okay, so the best time to schedule this patient's appointment that has hypertension like that would be early morning, especially someone early morning who's got like respiratory issues on case studies, because you want to get them in your office before everything is stirred up. And a lot of people are using aerosols and drills. I mean, it's all accumulating in the air. So early morning, it would take a while for all that stuff to accumulate. So that's why an early morning appointment would be better. People with that are super anxious, they are saying that sometimes afternoon appointments are the best for them because it would be the most relaxing time of the day. Okay. Be able to pick out the zygomatic process from a pano image. And I think that's it to this part. I also have this infection control. I made this last year. I'm not even, before I went, I'll put this on there as, oh, I'll have to give it to Professor Tresner to put on. It's just 15. It's talking about aerosols and splatter. I don't know if you want this or not. Chemical external indicators. Okay. I actually think I was trying to cover some things because this is all the stuff that we first went over in infection control. It just stops at biological indicators. Actually, I can try to finish some of this with this book. Would you like that? But they, yeah, this was an awesome. Also, have you been told about Natalie Myers? Oh, what does she call her? Is it the real RDH real or real RDH? She's okay. Yes, she's a student from last cohort. Okay, real RDH. She put together a really excellent, I think you've been talked to about this before, but she put together, actually, I was going to use a combination of hers and mine because I added some stuff to hers. And then I got in touch with her this weekend and she told me that she was selling hers, so I don't feel good about taking hers, her part of it, which really disappointed me. But she said, I think she has a discount of $49. She put together some really nice study guides, and she did excellent on boards. That's why she is such a good one to do this. She worked like a son of a gun all during studying for boards and put these things together for her class, which was so generous of her because she did so much darn work on them. and did really nice job with pictures and everything. So just want to, I haven't seen the whole thing, whatever she's put together, but I know whatever it is good and would be applicable. She has a really good memory, excellent memory. And so trying to remember things that are on her boards would be, she'd be right up on that. So I know it's another cost though. So I'll put together what I can and what I feel comfortable with out of and putting it in my own format out of here. And then when we meet again, we are, I guess we didn't get to go over really chapter 10. Did you have any questions over chapter 10? Oops, I mean chapter 15 or 10. I guess dental hygiene process of care. I feel so much like the dental hygiene process of care that you should know already, because that's what we do all day, every day is the actual, I mean, that's what you do every day that you have a patient. But I do know that on the boards, sometimes it will say that we could do a little higher in process of care. So I don't know how they have it. I'd really go over this, even though it looks to me, because when I first started going over it, I was like, oh, health history and intraoral, extraoral, and we know all that, but depending, really try to go over that again, and the ASAs and all that for case studies, and see if we can't get this. I just can't help but think that don't you guys feel comfortable with this part or no?
I feel better about this part than other parts, that's for sure.
Yeah.
I have a question on the recare intervals, because I know that, there's no like set in stone follow, 3-month, 4-month, 6-month, because we tailor it to the patient. But when I was doing the Darby's review case studies, I was just kind of confused because they were throwing in a lot of 6-month recares for perio patients, because I guess they had a year or so of good home care. And I didn't know, I was getting a lot of those wrong because I was saying 3-month. And then they were saying, well, it should actually be 6-month because they've shown that they can. I didn't know if there was like a certain kind of a guideline to follow with that.
Yeah, that's really upsetting because not only because it confuses you guys, but because it's insurance fraud. You cannot, once a patient has been, and that's not just from school. That's the way it is out in private practice. Not all offices, like I don't know if they forgot or I don't know what, and insurances weren't really picking up on it for a long time. But then it was kind of in, I don't know, maybe 2005-ish, 2006, somewhere around there. For 2 or 3 years, insurance fraud was a big deal. So they must have caught up with it and realized that they had become lax on checking, or I don't know what. But somehow it came to light, and they sent all the office managers, so many of them, they had invitations. Not everybody went, but they had invitations, and a lot of them would go to the seminars to find out from the insurance companies, and they would come back and go, oh my God, I had no idea we were committing insurance fraud. And they sent the hygienist to it, stuff like that too. So it really upsets me that something like Darby would come up with that. Let me do some research on that a little bit. I might not come up with much of a help, but I'll try.
Yeah, because like one of like in chapter 15, question 40, 49, it says what's recommended for a client who's maintained good results for the first year following non-surgical periodontal therapy. I originally had picked 4 to 6 months just because I went through for a middle ground because there was some 6 on their case studies, but then they said it was 3 to 4 because they had non-surgical. So I just was kind of confused.
Well, non-surgical period, that is SRP. So what recare interval is recommended for a client who has maintained good results for the first year following routine SRP but displays localized pockets? 3 to 4 months for sure.
Yeah, because originally, I mean, at first I was like, oh, 3 to 4, like that's for sure. But what made me question myself was some of their case studies on like the review on Darby's case studies. Because like I said, there's a couple 6 months. So then I paused because I was like, well, maybe it's not. Like I would think it's always 3, but maybe it's not. And so then I just got confused.
Yeah. Are case studies in the back or you have them in a different place? Oh, they're in a different place.
Yeah, they're online.
Interesting. Yeah, let me find out. Let me find out on that. I'm really interested to find out about the blood pressure. It's just not what I've been told, and I guess it's by such authoritative people. I just thought it was until I actually read it with my own little eyes. So thank you guys for. Yeah, I'll find out about that and then see. I wish I could just make copies of this book. I want to so bad. It was really an awesome deal. So you're not going to have Jane Weiner, right, as your boards? Is she not going to do your boards? Okay. And you're going to go with RDH? What's it called? Student RDH or something? Student RDH. Expensive?
Very.
Like 300 or 400?
Yeah, I wish I had known about the student from the last cohort before I spent the money on student RDH.
Well, yeah, and I don't mean to say anything against Natalie. I know she probably put together a really awesome thing, but remember this. Remember this one thing is that there are several, well, not just several, there's multiple, like maybe 5 or give or take, more different types of exams. So just because Natalie got one doesn't mean that's the same one you're going to get. You know what I'm saying? Now, I know she can pull up. I have no doubt that hers is really, really good. But almost wish you could do both. Almost wish you could do both. And even out of this book, that's why I wanted to bring this book to you. I mean, I can copy things down from the books that we're using and stuff too, but a lot of this just reminded me of things that we've gone after, and she said a third of the questions out of this book is on boards. And but then we can't, always use them. And so it's a condensed form, but I don't know. And they have a very high, I don't remember what it was, but it was an extremely high pass rate from this course. But you have to fly to Chicago, and then you've got to spend the airfare, and then you have the actual cost of the course. So it is not cheap. And they don't just have it, they go all around, because now with this COVID, they're probably doing it virtual. But they did go to, they only do it from like January to like March-ish, right before a lot of the 2-year programs always had boards, getting ready for boards. And when they're putting this together, I don't think the type of program that we have was on their mind when they were making plans. So I'm not really sure, but I mean, it was awesome, but it's expensive. It was like close to $1,000, just to be able to go do that. But I also went by myself, and so I paid for my own hotel and all that. So anyway, for instructors, we got to go to the actual, we didn't have to pay for the actual knowledge there, but had to pay for everything else. I mean, they can send 2 instructors per institution, I think a year free, and any more than that I have to pay. But I just felt I know you're getting a lot from the books. I feel more comfortable if I can give you, some good information from this, and you've got Darby, and you're taking RDH, and getting what you're getting from the different instructors. I don't know. I kind of feel like you should be able to at least pass it, with a 70, even if you got a 76. And I think many of you will get a lot higher. But also, I want you to keep studying and do your best, but also keep in mind that, if all of a sudden you're just so overwhelmed and you panic on the test and you're not a great test taker, the person who gets 76 has the exact same salary as a person who might get 98. What matters is that you pass. I know there's an awful lot to know, but I just think that you guys, I'm so glad to see that you guys have started this. When are your boards? You can take them whenever you want. You're written.
We have the HESI on, I think this like November 16th. And then she said if we pass that, then we can sign up and potentially take written boards in the next like 2 weeks or something. That's
right. I forgot about the HESI. And that's not exactly, and that will be just there's just so much to know. I mean, it's like, how much can you pack in those little brains of yours? It's like, I remember feeling the same way, like it's just, but I just have a feeling that if you're doing this, I know it was about this time that the 3 of us gals that were in hygiene school together, and we lived together. And I think I told you before, I mean, we get up every Saturday, 2 months, a month or 2 months before boards. We took boards, and every Saturday we wouldn't let each other out of it for any reason. No family birthdays, too bad. None of us wanted to retake it. We wanted this to be it and done so bad. And so we would get up and go into the living room and each take a chair and get our Coke or coffee or whatever we were going to drink, me Diet Coke. And we would go ahead and just shoot questions, at each other, just section by section. And if we didn't understand it, we'd go back and then we'd all be able to say, but we would just take turns, and we missed some and we got them, the other ones right. And it was just that's all we do for we take a 10-minute break and then we get right back to it, take a lunch break for 30 minutes, get right back to it, and weren't able to get up till 5. And I thought I was going to die. We probably, I think, were a little over bored on the study, but none of us, I don't care. I don't care if I studied more than somebody else had to study. I passed, and goodbye, to tests, and bye, Felicia. It's like you don't have to worry about anything. I didn't care. It's just let me pass. And I went out. I don't want to take any more tests anymore for the rest of my life, kind of business. And I want my life back, and I want to be able to make money. So, it's worth it. And if you're studying, you have to study more than your neighbor, or they just know more questions than you do. Just don't let it bug you. You just have to worry about you. And I hope all of you do better than 75. So I'm not saying shoot for 75 or you won't make it. Shoot for 100 and you'll make anything under that. But you do just have to pass it. And it takes what does it take? Missing 30 questions to go down 1% or 2 or something in how much you're getting right or wrong. You've got to miss a lot. Getting a 82 or getting an 80 isn't because you missed one more. It's because you missed maybe 20 or 30, however they gauge it, more to get to that. And still you're able to be a good hygienist. We have people who just, people don't take tests well. They study up until they're asleep. I had a very low temp, a 99 point whatever, something. And my head was hot. I just felt like you do behind my eyes when it was board time. We had to take it all together in a room on one day at one time. And there I went. And I was just like, oh, well, here we go. And different things can happen. I do feel, I know you're getting panicky about your board patients, because how many need still board patients? A lot. How'd your mock boards go? You know what I did too, and don't forget about this. I'm sure you've already been told this. Don't forget about I flipped the papers over. Don't forget to ask your dentist, your family dentist, and even if you're from out of town, they may know somebody here in Kansas City, because when I was out of the industry for a while, and then I came back into it, and I took a refresher course at Johnson County, and I had to have a board patient, and hadn't lived here very long, moved from Texas, and I didn't know anybody whose mouth was bad enough to go. And I just went around to some different offices. We hadn't even picked an actual dentist ourselves yet. And I happened to go to my first one. I had several in a row. And my very first one, I said, I'm wanting to find a board patient. And they gave me all sorts of names of people. And it was just on 100 and like, no, like 127th and Antioch, just an office. Because they also get people who need to have deep cleanings and do not have the insurance and for sure can't pay $1,200 or $1,500 or whatever they're charging for a full mouth deep cleaning. So they have to turn them away or have them go somewhere else. And so they may have an in to someone that would be nice for boards. I actually got a patient that was too hard for boards. I just was like, I'll take anything. And when I actually went over there, I was like, holy schmoly. And the director over there said, she goes, Jeannie, nothing like picking too hard of a patient. This is too hard. You did it and you passed and whatever, but this is not the type of patient. And I told her, I said, I wasn't picking and choosing. I took what I got, so it may be something that you guys won't run into that because you'll have to have them over to the office to the school to be able to do some paperwork and whatever on them. So you won't have to worry about that. But think about some ways. I had to get very creative. I thought it was going to be much worse than it wound up being. A gal who later we became really good friends who took that same course. I didn't know before I took the course. I had to she went to 2 or 3 or 4 different offices and it took her some time to find one, but she sure did. So when you're talking about that kind of money difference, you're talking about there's some people who might say, I'll go in there for 2.5 or 3 hours or 4 hours or make a couple trips for nothing. You know what I'm saying? Rather than $1,500. I don't know. You might try it. And if you're from out of town, you just never know if your dentist has some affiliation. They all go to these dental seminars and Midwest conferences and all of that. So just because you're from someplace out of town doesn't know that maybe your hometown dentist or regular dentist that your family goes to doesn't have some kind of connection up here for you to go to. Or you can just go in cold turkey like I did. Just go cold call a few dental offices. It's worth a try. Is there anything else you wanted to go over? No? So I will go ahead and record. I'll go ahead and get this going. Let me add a few things on this infection control. And I might just add a few things about the process of care, just to remind you over that they have in this book. And may take about a week. Depends on how much time I've got between my classes. I'll try to figure something up and then also make something up. Kind of have a little bit over the perio and the instruments for you. I've already got that all from this book. So anyway, we can hit it from all fronts. Okay? Okay. You guys have a great evening. And if you need to know anything else, email me. Or if there's something else you want to find out. Okay? Have a great one. Andy?